Hello everyone, my name is Emily Martin and the working title for my project is Breast Cancer Risk for Female Relatives of Male Breast Cancer Patients with Negative BRCA1 and 2 Testing. This slide lists the members of my thesis committee. Megan Kalfas is my ghost chair while Rachel Bluebond is my acting chair for the project. Leslie Dennington is my member outside of the cancer specialty, and there are two MD Anderson physicians, Dr. Arun and Dr. Giordano, on the committee as well. Dr. Christine Peterson is a statistician with MD Anderson who will be working on the project. She declined to be on the committee due to the fact that she is currently on 7 other thesis committees right now. I'll start by going into some background on what we know about breast cancer and some of the risk factors. SEER data from 2019 lists breast cancer as the most common non-skin cancer diagnosed among women. Approximately 268,600 new cases were diagnosed last year, with an estimated 41,760 deaths. Currently, the lifetime risk for a woman to develop breast cancer is 13.2%. Conversely, male breast cancer is considered rare and accounts for less than 1% of all cancers diagnosed in men. SEER data from 2019 estimates that 2,670 new cases were diagnosed last year, with approximately 500 deaths. Currently, the lifetime risk for a male to develop breast cancer is 0.1%. We know that 5 to 10% of breast cancer is caused by a pathogenic variant in a gene related to hereditary breast cancer. And of this 5 to 10%, about 80% of the mutations have been found in the BRCA1 and BRCA2 genes. Females with a mutation in BRCA1 or 2 have up to an 80% lifetime risk to develop breast cancer, and males with a BRCA2 mutation have up to a 7% lifetime risk to develop breast cancer. Additionally, it is thought that the risk of male breast cancer is slightly increased in the presence of a BRCA1 mutation, with an estimated lifetime risk of 1 to 2%. We also know that family history of breast cancer is a risk factor for an individual's lifetime risk to develop the disease. Sang et al. Published a paper in 2017 examining the relationship between male breast cancer and other cancers observed in families. Through statistical analysis of their data, they found that having one female first-degree relative with breast cancer incurs a relative risk of 1.76 for male breast cancer. Having 2 female first-degree relatives with breast cancer incurred a relative risk of 2.28 for male breast cancer. And they also reported that having 1 male first-degree relative with breast cancer was related to a relative risk of 1.9 for a female to develop breast cancer. Through my literature review, I did not find any study that evaluated familial risk incurred by a history of male breast cancer in the absence of a genetic mutation. We know that male breast cancer is considered rare, and among that cohort, it's estimated that 15% of all cases of male breast cancer can be attributed to a pathogenic variant in BRCA2. This number has been reported to be as high as 20% in certain founder populations. So among the studies that have looked at familial risk caused by male breast cancer is the increased risk for breast cancer that's been observed due to a BRCA2 mutation, a multifactorial mode of inheritance, or a combination of the two. I feel this topic is important to help determine whether or not sporadic male breast cancer is associated with an increased risk of breast cancer for female relatives. Knowing this information can help to make more accurate screening recommendations during post-test counseling for the families of these male breast cancer patients. So this leads to my research question, which is a family history of male breast cancer that is not attributed to a BRCA1 or 2 mutation associated with an increased risk of breast cancer for female relatives? The aim of this project is to investigate the incidence of female breast cancer in families of male breast cancer patients following negative BRCA1 and 2 testing, with a sub-aim to compare the incidence of female breast cancer among families with a family history of male breast cancer to those without. Now I'll talk about the methodology for the project. So this is a retrospective chart review that will compare the incidence of female breast cancer in families using a 1-to-1 ratio of matched cases to controls. The sample population will be male breast cancer patients seen at MD Anderson for genetic counseling with subsequent negative BRCA1 and 2 test results. The control group will be male prostate cancer patients seen at MD Anderson for genetic counseling with subsequent negative BRCA1 and 2 results. The controls will be matched to cases by current age within a 5-year range, ethnicity, and family size, which will be determined by the number of first and second degree relatives in a pedigree. Since we are matching cases to controls, we have plans to utilize the male pancreatic cohort seen for genetic counseling at MD Anderson if that's necessary to appropriately match all cases with the control. For the sample population, we will include males with a personal history of male breast cancer seen for genetic counseling at MD Anderson and who have negative BRCA1 and 2 test results in their medical record. We plan to exclude individuals without test results in their medical record, individuals positive for a genetic mutation for a different breast cancer predisposition gene, such as ATM or CHEK2, and males with a previous cancer history of prostate cancer or lymphoma who later developed breast cancer. The reason for the last one is that during my review of the literature, treatment-related exposures, specifically those involved in treating prostate cancer and lymphoma, were cited as a risk factor for male breast cancer, so we decided to exclude these individuals from the study. For the control population, we will include males with a personal history of prostate cancer seen for genetic counseling at MD Anderson, who also have negative BRCA1 and 2 test results in their medical record. We will exclude individuals without test results in their medical record and individuals positive for a genetic mutation in a different breast cancer predisposition gene, such as ATM or CHEK2. If we end up utilizing the pancreatic cancer cohort as part of the control group, the same criteria will apply for them, aside from the difference in cancer diagnosis. To determine sample size, I queried the Progeny database, and Progeny showed that there were records for 8,892 males seen for genetic counseling at MD Anderson. Of these, 221 were males with a diagnosis of breast cancer, 136 of which had negative BRCA1 and 2 genetic testing. So this is the sample population that I plan to work with, and that number may decrease slightly based on the inclusion and exclusion criteria I previously mentioned. For data collection, I created a spreadsheet to organize the data points I plan to collect. These data points include the patient's age, ethnicity, personal cancer diagnoses, age of diagnoses, type of genetic testing performed, the results of the testing, number of female first-degree relatives, number of maternal and paternal second-degree relatives, and number of females with breast cancer among first-degree relatives, maternal second-degree relatives, and paternal second-degree relatives individually. I uploaded a copy of my data collection tool to my personal folder in the Approaches to Research class drive. Currently, there are 272 charts that I plan to review for the project, and that is composed of 136 cases and 136 controls. My goal is to finish data collection by October, so when splitting that up into a weekly goal, I plan to review approximately 21 charts per week between August and October. For data analysis, I plan to analyze the demographic information with descriptive statistics. The incidence of familial female breast cancer will be compared between cases and controls. And at the moment, we are still discussing if and how we want to include second-degree relatives into data analysis. I have not yet had my thesis committee meeting, and this is something that I plan to ask for feedback on during that time. We decided to go ahead and collect that data in case it is included in analysis, but for the familial incidence of breast cancer, I'm planning on using logistic regression analysis to produce an odds ratio, and the p-value will be less than 0.05. Based on the discussion I've had with Dr. Peterson, the project statistician, the goal is to have a power of 85%, which she helped me calculate based on the numbers we have for the project so far. For covariates of the study, our main concern was additional risk factors for male and female breast cancer. These included environmental factors, other cancer diagnoses that could be related to female breast cancer, and unknown genetic risk factors. We also acknowledged that the control group is not a healthy control group, but this could also be seen as a pro, as their family history is more likely to be complete in progeny compared to another MD Anderson patient who was not seen for genetic counseling. Ensuring that all cases and controls have negative BRCA1 and 2 testing and matching for some of the well-established associations with breast cancer, such as age and ethnicity, were ways that we chose to try and minimize these covariates. As far as limitations, the sample population is small and will limit data analysis. Additionally, having family members with no reported breast cancer will also impact data analysis, since we can't use an incidence of 0 for logistic regression. This page includes my references, and that concludes my presentation. Thank you all for listening.